Everything's working. And so we're almost at the end of class. I can't believe it. This is week 6. You have this week, you have next week, which is week 7, and then week 7.5 is a really, really short week just to prepare you. Okay. So that's going to be your short week. This week is your biggest week as far as assignments. You'll see there's quite a few. So if you're late getting them in, don't worry about it. Take your time. I'd rather you feel comfortable with the material than to rush to get everything in. So just take your time, submit it. You have till the end of class. Okay. So if you want to take till the end of week 7.5, that's fine with me. Okay. Tonight, we're going to go over the final portion of the portfolio review. I'm still grading some from week 5 from last week. I should have them finished up tonight with my feedback. So I'm going to go over week 7 portfolio review. This is the easy part. Going to go over your CCA practice exam information. Going to go over some terminology for you as far as instructional notes and symbols and notations, just kind of like a refresher for your exam. And then I'm going to introduce you to a physician query, what that is. You guys touched on that in your lecture this week. So this is just a review from week 3 portfolio. I just basically put some information in here as far as what the answers were for you for week 3, how we got those, and what instructional notes you would use. So I'm going to supply you with these PowerPoint slides. I did give everybody very detailed feedback for week 3, but if for any reason you missed that or you just want to go back and review again, your answers to week 3 are going to be here. So this was the first scenario. And the second scenario, same thing, gave you the answers and how we got there. And same thing for the third. Okay, so you can go back and review that if need be. Your final portfolio project, you're going to review the feedback from week 3 and 5, make any corrections. So you really want your codes to be accurate and correct because this is your finished, polished, good copy. This is the easy part. You're going to write a short essay describing your knowledge and your skills that would demonstrate why you would be most qualified to be a lead coder position. Now, let me phrase that, lead coder. On a lot of the homework assignments, I'm seeing some students that are using the word coder in terms of a computer programmer coder. Okay. So we want to differentiate between the two. We are not computer programmer coders. We are medical coders. So I did give some students feedback that they're using, and they must be searching and pulling incorrect information into their homework assignments. So whenever you're looking up information for your homework assignments, or especially something like this, you want to focus on medical coder, okay? You want to put that first. So you're going to do a short essay, why you are most qualified. Think of it like a cover letter, like you're applying for a job. You want to talk yourself up. You can go to Indeed. You can go to LinkedIn. You can go to Glassdoor. You can do AI. Search for job descriptions for a lead medical coder, coding supervisor for a medical coder, things like that. And that will give you some really good job descriptions about what those jobs entail. And then you're going to kind of go through that and find attributes in there that kind of describe you. Okay, so this is all about you. Can't be right or wrong. Maybe like a paragraph or 2. And then you're going to put week 3, your coding examples, and then week 5. Okay. Everything is going to be on one document, double spaced. This should take up about 3 to 4 pages in length because you're going to be double spaced. Okay. And then you're going to upload that like you have been. You're going to upload it for next week for week 7. Any questions about that for those that are on the call?
No, ma'am.
Okay. All right. And you can feel free to email me a copy if you want me to kind of give it a glance over prior to submitting it. Just email it to me and I'll take a look at it and give you my feedback. You don't have to. If you want to just submit it, that's fine as well. So whatever your preference is. And please make sure to use grammar and spell check. Okay. So just to give you some more tips for the essay part for the week 7 that you're going to do, you want to persuade people that you're the best person. So I already went over, you're going to search lead medical coder, go for supervisor medical coding, things like that. Okay, so those, I just put everything in a slide for you. Your practice exam opened this week. It's available to you now. Okay, it is on Cengage. So that's why we had you put an account in with them the first week of class. You have till the end of week 7.5, but please don't wait till the end because this does take a little bit of time. You get 2 attempts. Your highest grade is what's going to count. Okay. 50 questions and you have 90 minutes to complete. So again, for this one, it doesn't matter what kind of notes you have on your desk. This is open book. So if you have notes on paper, anything like that, don't worry about it. You can use whatever you want. This is open book. The thing where you can't have the loose leaf papers is going to be when you take your real exam. So don't confuse the two. This one you're taking at home. This one really, it doesn't count. It's just a practice exam. It'll count towards your grade. But it's not going to say, yes, you're going to be a coder or no, you're not. This is just part of this course. Okay. So take your time. Please don't stress out about it. It's just to prepare you so you see what the real exam is going to be like. Okay. But once you open it, you're in it. You can't hit a thing and stop it. Once you're in it, that clock is going to keep on running out. Okay. So just remember that. So make sure you, study for that. You again, open book, ICD-10 only, so only diagnoses, only information covered in your lectures and class. That's all that's going to be on this. Okay, and I will put a little study guide out there too this week. So you want to prioritize your time management skills, set up a quiet zone, make sure you're getting your sleep and eating well. Don't stress about this, please. Stay confident and positive and make sure your book is tabbed. If your book isn't tabbed, it's going to take you a lot longer flipping through. So tab your book. Okay. Any questions on that practice exam that you have till the end of class to take? Week 7.5, it closes. Any questions? Okay. All right. So all the stuff I'm going to go over, these couple of next slides for instructional notes, symbols, things like that, it pretty much should be a review by now. If not, I would definitely make sure you notate these definitions because you're going to need to know these in order to code properly. So your instructional notes, that would be, it defines a condition within a specific code. So your instructional notes clarifies what is included within that code, okay? Your excludes one, okay, so excludes one is going to let you know what conditions are completely separate from that code that you're looking at. So these codes should never be coded with this code. So it means not coded here. So excludes one means not coded here. Can never go together. Okay. Excludes two means it can go with it, but it means that it's just not included with that code. So you might have to do some digging around and see if maybe it should be included. It can be. It just means that the code you're currently looking at doesn't include that in there. So 2 different terms, 2 big different terms there. Code also is one that you should be real familiar with, very easy one. That just tells you, hey, look, you need to code this in addition to this code. So you need to code also. Okay, so it means another code is needed to fully capture the condition that you're trying to code. Okay. Use additional code. It's similar to code also. It means that an additional code should be used, and it is often used to identify a manifestation of a disease. So maybe if a disease started some way. They want you to see how it manifested, how it got to where it is today. So there'll be something in there that says use an additional code, and it'll tell you use like E11 through E14. So you're going to have to pick one within that. So it does tell you. That's the good thing about your code book, is it does tell you what other codes you should be picking from. You just have to pick what one's relevant for your patient. Okay. C also is going to take you to another location in the code book for further information. So it's going to say, look, you also have to look here for more information on this code. Okay. C condition is going to just direct you to the appropriate code for that condition. So maybe that condition has various names, could have more than one name. It's just going to direct you to the appropriate name of how they have it organized in the book. So that's what that means. Okay. It takes a little bit, especially like the excludes 1, excludes 2 to kind of get it. So these are ones that I would definitely write in your book, especially like in the back where you have all those empty pages. I would write these kind of definitions back there. I think it'll be really helpful for you. So that's just a little bit of what I would recommend that I put in my book when I took my test. You always don't remember it. So why are these things important? Why do we need them? Well, it helps ensure accuracy, okay, consistency, right? Because there are 3 of us on the call, and I can tell you that if we are working in an office today and we're looking at the same patient's chart, we're going to code it probably 2 or 3 different ways. It's just how it is. And we're going to talk about it, and we're going to say, why do you feel this? Why do you feel this? And then we're going to come to an agreement. I see it happen all the time between coders. I do it with my own group. So consistency is something that by following the book, it kind of helps with that. Not all the time, but it gets us in the right direction. Okay. Also specificity. As I mentioned before, when you're coding and you're getting reimbursed, the healthcare provider is getting reimbursed for these codes. The more specific the code is, the higher the reimbursement. And that healthcare provider wants the most money that he can get, right? Because he's doing a lot of work. So we want to make sure that we are doing right by the provider and we are coding to the highest level of specificity. Also, we're doing right by the patient when we're doing that, because the patient is going to maybe be involved in a study or a research grant. And that 1 or 2 digit difference on that code that we're doing can make or break if that patient gets into the study or doesn't. So we want to make sure that we are as clear and as specific as possible when we're getting those codes. That's why just 1 digit makes a big difference. It also helps avoid coding errors. So using those excludes 1 and excludes 2 notes, it's really crucial. And that's why I would put them in the back of your book. And then compliance, you're going to hear that word from now till forever. Just making sure that everything we do is compliant with coding regulations and guidelines. We always want everything we do to be compliant. Okay. So your tabular list instructional notes, just showing you what it looks like. I put a little snippet in here for you. The code first, it shows you this is actually out of your book. So it says right there in red. So if we were looking at this H94.0, acoustic neuritis and infectious and parasitic diseases classified elsewhere, it tells you, hey, if you want to use this code, you need to first code the underlying disease, which is most likely a parasitic disease, and they're giving you where you can find that at B65 to B89. So it's telling you, okay, you're coding acoustic neuritis, but it's caused by a parasitic disease, so you need to code that first. So your book tells you right where to go. So here's another example for use additional code this time. The use additional code means that more than 1 code is required to fully capture what's going on with the patient. So this is one you're going to see a lot. Diabetic patients, a lot of diabetic patients have other things going on with them. Okay. So this patient in this case has diabetic retinopathy. Okay. So they can't have diabetic retinopathy if they don't have diabetes first, right? How else are you going to get diabetic retinopathy? So it tells you that the primary code would be for retinopathy, but there's going to be a note there saying use additional code, and it directs you to code the type of diabetes the patient has, either type 1 or type 2. So it tells you right there that you need to use that additional code. Okay. Your history codes, you're going to see that a lot. Your history codes, things like your Z codes for personal history. So for this example, Z85, personal history of a malignant neoplasm. Z82, personal history of another disease like a myocardial infarction, things like that, family history. So all of that is going to be in the Z codes in your book. So they are all personal history codes that you should be aware of. So just know that your Z codes are the history codes. So going back to the excludes, our excludes 1, again, means cannot be coded together, can't be coded here. Okay, so you have to remember only one code can be assigned. So this is just another little snippet of that. Here's an example. If a patient has a specific type of pneumonia and it says excludes 1, pneumonia due to influenza, that means that the patient's pneumonia is caused by the influenza, that you cannot use the code for the pneumonia. You would instead use a code for pneumonia due to influenza. So it's just getting more specific and telling you that you have to go the extra step to do that. Okay. Excludes 2 means, again, it's not included, but you can include it. So you just have to look and see that the 2 conditions can coexist, but you would have to code them both separately. Okay. An example would be osteoarthritis. So this means that if the specific type of arthritis covered by the code doesn't say osteo, then you would need to code both of them, the arthritis and the osteoarthritis code. Okay, not just the osteoarthritis. You would need arthritis and osteoarthritis. Again, your book will tell you if the code needs that. So just follow your book. Your book's going to be your best friend. Combination codes, you only assign that when the code fully identifies the conditions involved, when the alphabetic index directs you to. A combination can be used for a couple of reasons. It classifies 2 diagnoses. It can classify a diagnosis that has a secondary process happening, like another manifestation, or it can be a diagnosis that has a complication. Okay, so that's your combination codes. Again, your book will tell you. Here's an example. This was from week 4 from our case studies and our discussion board. So if any of you had this case, it'll look familiar. Patient was diagnosed with diverticulitis of the colon with perforation and abscess with bleeding. So the combination code, when we went through everything, it was K57.21. And that one code covered all of that, covered all those codes below. So it combined all of that into one code. So we didn't need to code everything separate. We just needed the one code. Okay, so it will tell you that. So that way you're not adding extra codes if you don't have to. Back to your diabetes, because again, you're going to see that a lot. They a lot of them are combination codes. It talks about what type 1 or 2, what body system is affected, what kind of complications. So you're going to see a lot of things with diabetes. For instance, in this example, we have a patient that came into the wound care clinic, had type 2 diabetes with a right heel ulcer. Okay. A lot of times people with diabetes will get ulcers on their feet. this patient had that. Patient also has complications of type 2 diabetes with hyperglycemia, okay, which is high blood sugar. And CKD is chronic kidney disease. That's another condition that diabetics get, stage 4. So it's in the last stage, stage 4. So when we go to code for this, okay, it's going to tell us that we need to code type 2 diabetes with a foot ulcer. We have to then code for the hyperglycemia for type 2 diabetes. And then we also have to code type 2 diabetes with the chronic kidney disease. So for something like that, where they're coming in with the foot ulcer, but they also have complications of hyperglycemia and CKD, that's 3 things. So we have 3 separate codes that are needed. And again, your book will tell you that you need to do that. Unspecified codes, we really try to stay away from unspecified codes. Why? Because they're not specific, right? So in a few minutes, I'll be talking about querying physicians. And a lot of times I query a healthcare provider if they're lacking in their diagnosis with the specificity, if they're not giving me that information I need. Like if the physician had only said patient has diabetes, I would go back to the physician and ask them to clarify in the note what type of diabetes, because there's type 1 or 2. So the patient has to have either one, and I need to know that to code properly. So those are things you would query a physician for. So unspecified codes, if there's instances where maybe you're coding for something like an emergency room where you really can't get a hold of the provider, things like that, we can try to make do with the unspecified codes, but in most situations, you're going to be able to query a provider. If you can't, the unspecified code will have to do, because that's all you have. And we can't make up things. We can't assume. You have to go with what's in the note. But if we can get them to clarify in the note, that's your best course of action. That's what you should do. Try to query to get that most specific that you can. Another thing I query for a lot of times is laterality. You'll see that. So for example, this condition that we're seeing here for knee pain, it can be in the right knee, can be in the left knee, or it can be in both knees, which would be bilateral. Or if the provider doesn't tell us which knee it's in and we can't really get a hold of them to find out, we would use the third one there, the M25.569 for pain in unspecified knee. But again, when an insurance company sees this, if another healthcare facility were to ask for this patient's notes because maybe the patient transferred over, the provider really should be specifying what side of the body the pain is on. It's good practice, and the providers know that. Sometimes they might forget or just get busy, but it really should be indicated in there. Okay, so make sure we have 2 sides of our body. Most things have a right and a left on our body, so make sure we're knowing what side it's on. Our coding guidelines, we've gone over numerous times. I talked about them when we did the tabbing. We went through these with the 4 sections. So if you haven't tabbed your book yet, here's your 4 sections in the front of your book that you want to tab. So 4 coding guidelines. And these, I broke them down for you. So it tells you what each one encompasses, in case you want that. Okay. Then we also have gone over, and I've put in tons of things in the discussion board, the announcements for your inpatient coding guidelines. So I just put it here for you as well. If you want to have this to study or write in your book for your practice exam, your inpatient coding guidelines. All right, that's the condition established after the studies are done to be chiefly responsible for that patient's admission. Okay. Section 3 of the coding guidelines talks about secondary diagnosis. That's something that is defined that coexists at the time of the admission. So maybe the patient came in for something, like let's say the patient came in because they had a headache, right? But the patient also has arthritis in their knee, and they have atrial fibrillation. They're having some flutters in their heart. If any one of those can affect the treatment, then that's when we would want to code that for that secondary diagnosis. Okay. So that's in regards to your hospital stay. As long as it has an impact on that treatment, then we would code. Okay. If it doesn't have any bearing, don't code it. It just has to impact that treatment. And then I put your outpatient guidelines for you again. Okay. We're going to be coding signs and symptoms because a lot of times we do not have the actual diagnosis. But if the provider says it's something that they feel it pretty much is, like there are COVID examples, then we would go ahead and code that. But for most of your outpatient, you're going to be coding signs and symptoms. Just because the test might not be back yet. I also put a step-by-step guide for you just to go how to find a code, right? To find a code, you need to understand your coding guidelines and conventions. You have to have that written diagnosis in the note from the healthcare provider. And then you're going to go to the alphabetic index first. And then you're always going to verify in the tabular list second. So those are your step-by-step. Any questions so far on all that? That was all review.
No, ma'am.
No? Okay. So what is a physician query? Again, this is my world. I do it every day. So physician queries, I love them. You are communicating to providers to try to get a complete picture of what went on that. I always tell the providers, this is your diary. This is your diary. So make sure it captures everything, because I'm not in the room with them and the patient. So I don't know what happened. I don't know what they talked about. Neither does the insurance company, right? So everybody who's not in the room needs to be able to read those notes and get a really good, clear picture of what happened or what's going on with the patient. So a query is used to reach out to the healthcare provider to see if we can get some more information for something that might be lacking or that we need clarification. Okay. So when to query? If there's conflicting information, okay. I had the case where I was doing coding for a knee surgery, and the whole op report said right knee, but everything, all the scans, the x-rays, the MRIs, CAT scans, all said the opposite knee. So I needed to know what knee did you operate on, because all the test results say left, your op note says right. So which one was it? Can you please check? And I always say addend the note. Please addend it, like make your corrections. So if you have conflicting information, make sure you do that. If you have incomplete information, sometimes they just forget, and they're in a hurry and they're on a time schedule. So maybe they forgot to finish their note. Maybe it's incomplete. Okay. If there's clinically relevant information that wasn't addressed that you need in order to code and something is missing, then you could query for that. Okay. If anything significant is missing, maybe a procedure, maybe at the end of the note, the provider said that they did a urinalysis on the patient today, and you're reading the note, but you don't see that an order was ever placed. We can't, as coders, code something like that unless the order is in there. So things like that for procedures, you might query. So if you answered yes to any of them, yep, we should query. When should we not query? I can tell you that healthcare providers can sometimes become very protective of their work. And we never, never, never want them to feel like we're questioning their judgment, right? So we never want to query them and say, hey, you diagnosed Mrs. Smith with pneumonia. Are you sure you didn't mean this? We never want to do that. We never want to query if in our mind we're saying that the benefit is strictly for reimbursement, right? And we never want to query if there's insignificant findings or for irrelevant information. So if we really don't need it to code, we're not going to query and bother the provider. We only want to query when it's absolutely necessary. They're very, very busy and they do not want their inbox filled with things that are not supposed to be there. So a HEMA, as you all know, you signed up with accounts with a HEMA because if you go into medical coding, you will be certified by a HEMA. So this is straight from a HEMA's website on queries. You want to avoid leading queries. We never want to lead the provider to the outcome that we're looking for, okay? We cannot ask them in a yes or no answer. And we always have to put in our query that there's an option that maybe they don't have any additional documentation. So if you ever query, most organizations you work for are going to have what's called a canned query, which means it's a standard query for each scenario you're going to come across. So if I query, Andrea queries, Felicia, Melissa, we all query, it's all going to be the exact same words, all the same verbiage if we're in the same organization. So those providers are going to know that it's a standard query. So we're not going to have all different words and everything. So it's going to be standard and you won't have to develop your own queries. It'll most likely be already there for you. So here's an example of a leading query versus a non-leading. A leading query would say, please document the cause of the patient's altered mental status. So I'm asking them to document. The better way to write it so it's not leading would say, can you clarify the cause of the mental status? So I'm asking them to clarify. So just a little word difference like that makes a big difference, which is why I can be 99% sure that your organization you get hired with is going to say, these are what we use, only use these, because compliance has approved them. They don't want to get in trouble with these big organizations out there, like CMS for Medicare and things like that. If the charts get audited and they see that Jennifer Blake was asking leading queries, I'm going to get in trouble and the organization's going to get in trouble. So you're going to have canned queries, but this just gives you an example. So again, here's another example of a leading query. Since the patient has a history of smoking and presented with cough, it's likely pneumonia. So please document pneumonia. So that's me telling the provider, hey, document pneumonia. We never want to do that. So a better query would say the patient presented with a cough and has a history of smoking. Please provide your assessment and diagnosis based on the patient's presentation. And please include any relevant findings and diagnostic test results. So that will prompt the provider to do their own assessment versus me, Jennifer, telling the provider to document pneumonia. So that's just a difference. Okay, so that's all I had for tonight. I just really wanted to kind of get you some information on your practice exam, on your week 7 portfolio, and to explain a little bit about the query process that was touched upon in your lecture. Does anybody have anything for me? Any questions that you want answered? Anything that I can go over?
Yeah, I do. Because
Okay.
I keep getting confused about like when I'm coding it, whether I'm supposed to code everything or just, certain things. Because last time I coded too much, and then this time I don't think I coded too much, but I coded a lot still. You know what I mean?
Okay. Yeah.
Yeah.
So what I would suggest for you in this slide presentation and in many of the discussion boards and announcements, I put the coding guidelines for inpatient versus outpatient. So that's the first thing. When you're coding inpatient and outpatient, there's different coding guidelines. So for outpatient coding, you're most likely only coding the signs and symptoms because we wouldn't have a confirmed diagnosis yet. Most of the time, you're only going to be coding signs and symptoms for outpatient cases. Okay. For your inpatient cases, you're really not going to be coding signs and symptoms because by the time the patient leaves the hospital, we're going to have a confirmed diagnosis. Okay. When you are assigning your codes on these coding cases to determine how many codes you need, I can't tell you because every case is different. And how it's different is when you're looking up your first coding term, right? Let's say the patient came in with 3 things and you go to your first term. That's going to say, okay, you're going to stop here. You don't have any more. Or it might say code also, or it might say go here. So depending upon where it directs you to go in that tabular list in the back, that tree that you follow from each thing is going to determine how many codes you need for, first of all, one diagnosis. One diagnosis, you might have 2 or 3 codes based upon what the book tells you. Okay. Secondly, I can't tell you how many you might need because it might be a case of where it's a combination code. So maybe all 3 codes are included in one code. The book is going to tell you that. So you have to really, really, really follow your tabular list in the back and kind of follow those directions that it gives you in the red. A lot of times it's in the red letters as to what codes you're going to need because every case is going to be different. Does that kind of make sense?
Yeah, it answered it. I'm good.
Okay. All right. And if you go back, I'm trying to see my slide deck here. Hold on one second. Just real quick, I can show you an example. Sorry. Let me just find it real quick. Trying to find my red real quick. There we go. Okay, so for this example, for a code first, this when I looked up in the tabular, I was looking for the acoustic neuritis, right? And in an infectious or parasitic disease. And when I looked under the H94.0, in the red, it said you must first code the underlying disease, such as a parasitic disease, B65 to B89. So that's telling me right away, I already know I need 2 codes for that one diagnosis because the book is telling me. That book is saying, look, you got to code something else first in addition to this code. And it's up to you to go back to the notes and see what kind of parasitic disease you're looking for that B65 to B89. Your physician's notes is going to tell you what kind of parasitic disease it is. So then you got to go to B65 through B89 and see which one you should code. So that's what I mean about if you need like another code for one diagnosis, your book is great. Your book is going to tell you what you need to code.
Okay, well, like for case 4 of this week, how it says, due to this, due to that, due to this. We're supposed to code all of those, right? Because they're underlying conditions.
Now hold on a minute. Let me pull up case 4 because I don't have it up. I know some for case 4, I think were external codes or let me see, hold on 1 second. And you're talking about for the discussion board, right?
Yeah.
Case 4, okay. I have it on this computer. I just have to just bring it up. Okay, so for a case 4 for David Burton, there are 3 codes that are required. He had renal failure due to severe sepsis that resulted from him having streptococcal pneumonia. So what you need to do first is he was diagnosed with acute renal failure. So you want to try to code that first. And then it's going to tell you if it was renal failure due to, you have to follow that tree down and look at your guidelines on how to code that.
Yeah, well, I already did it. I was just curious because, like I
Yeah,
said last,
so there's 3.
Yeah.
Yep. So there's 3 codes that are required for that case.
well, I did 4.
Okay, so you had one. I know what you did. You coded J14.30, right, for pneumonia. You had the J
J1,
code in there, and that's not
yeah,
needed. Yeah, the J code's not needed.
okay.
No. Yeah. But it takes time. And if you had 3, you had the other 3, girl, that's good. You're doing good.
Okay.
Everybody's been doing very well. I have nobody like for I have 2 classes going on right now, and for everyone in these classes, I have not one student that I'm worried or concerned about. Everybody's doing absolutely phenomenal. So
Nice.
everybody's doing very well, very well. It's not easy. This is not easy, and you are learning this in a very short amount of time. It's not
Yeah.
easy. And it's an evolution throughout your life. You're constantly going to be learning this because the codes are constantly changing. I get guidelines every day sent to my email. Like I have folders everywhere. Like you're going to learn every day and everything changes all the time. So it's
Okay.
always going to be a learning adventure. So that's the fun thing of it. It's always something new to learn. You're not going to get bored. I can tell you that. Anything else, anybody I can help you with?
Are these tests, when we do the state test, is these local or we have to go somewhere?
So it depends. When you are ready to take it, you'll be given a voucher. Okay. And you can go online and put in your zip code and it will tell you. So I think I had to drive like an hour to get to one before. I am a chapter president and I administer tests, and I have heard of some people traveling like to another state for them, where they've spent the night in another state. So it really just depends upon where you're located, um, where they're offered. So once you get your voucher, you'll be able to, if they'll give you a code, you have to go online, put in your zip code, and you can't do that until you have your voucher code. So yeah, I've heard of people having to spend the night and travel, and I have heard people where it's like 15 minutes away. I always had to go like an hour for mine.
I was just wondering.
Yeah.
I was a little confused with the timeline with that. Like when we're supposed to take that test.
Yeah. So for this class only, right now your practice CCA exam, which is only on diagnosis coding, ICD-10, that is open now. And you have until the end of when class ends, week 7.5 to take that. You have 2 attempts, 90 minutes. It's open book, open notes. You can do what you want. It's just to prepare you for the real one. Your real one you will not take until after you're done with your program. So whether you're going for the degree program or the certificate program, once you're all done that is when you will schedule to take your real exam. That exam is typically a couple hours. I think mine, they gave me 4 hours to take. And that's where I said they're really strict with your book and you can't have like notes falling out or sticky notes. You can write in your book, but don't have any loose leaf things or sticky notes.
Yeah, I watched that video earlier
Yeah.
about that. There's a lot in that video.
Yes.
It's kind of intimidating.
Yeah. Yeah. They're very strict. They're very strict with their tests. So not that we try to scare you, we're just preparing you.
Yeah.
You know, of what to, because I went in there, God, years ago when I took mine, and they're like, you can only have a pencil. I couldn't bring my own paper, couldn't have my cell phone. I had my car key. That's it.
Mm.
I was afraid to drink anything because I didn't want to have to go to bathroom because they do let you
Yes.
use the restroom, but the clock doesn't stop. So if you get up to use the restroom, like your clock is still going. And I used all 4 hours for my test. So I didn't want to lose no time. So I said, I'm not going to bring anything to drink, you know. But they
Mhm.
don't let you bring a watch in, you know, I have none of that.
Yeah. Well,
This
she
is
said it
it.
came down to what, like a minute per question. That's that's tough.
Yeah. And you know why they do that too? They do that because if you're absolutely going to be a coder, most companies are going to hire you and they're going to give you a test to take first, and they're going to time you because they want you to code so many charts per hour. So they're going to say, like, we're going to hire you. And it depends. The charts per hour are going to depend on what you're coding. So if you're coding inpatient charts, they might say 3 an hour because those charts are pretty thick. If you're doing like a doctor's office visits, like ambulatory, they might say 12 an hour. So you really have to be fast, and they stick to
Yeah.
that. And then on top of that, they audit you. So they're going to say you need to have like a 94% accuracy rate when we audit you. It's very, very competitive. So that's why Dr. Perillo really hounds that in so everybody's prepared.
Okay. And so there's 3 coding classes, right?
Yes. Yeah.
3. Yeah. Okay.
Any other questions? Anything you need help with?
No, ma'am.
All right. I will post this. It takes a little bit for me to upload it. I'll have all the rest of the portfolio projects that were submitted for week 5 graded and back to everybody by this time tomorrow. And other than that, good luck on your practice exam. And if you need anything in the meantime, let me know. I'm always here for you.
Thank you.
All right.
Thank you.
Have a great night, everyone. Thanks for coming out.
Bye.
You too.
Bye.
Bye.